Hi, thank you so much for joining us today in this virtual environment for our lightning talk. My name is Priti Lakhani. I am one of the council members and a co-chair of the Reunion Week. We're so grateful for your time and to have you here today. I think this is going to be well worth the effort. Our first lightning talk is Dr. Rasha Khoury. She's a Palestinian physician and public health activist. She was born and raised in East Jerusalem. She moved to the US for medical training, graduated from Yale School of Medicine in 2008, and completed her residency in OBGYN at UCSF. She then pursued a fellowship in global women's health at Brigham and Women's and received her MPH from our illustrious school in 2013. In 2014, fulfilling a lifelong dream, she joined MSF, also known as Doctors Without Borders, and has since completed 6 surgical missions in Africa, Iraq, and for more than a year in Afghanistan. Last year, she joined the board of the directors at Doctors Without Borders to exercise participatory leadership, uplift and amplify the voices of patients and global staff in the MSF movement. Dr. Khoury currently works clinically in a high-risk OBGYN clinic in the Bronx in New York City. She has a research focus on reducing severe maternal morbidity and mortality. While examining the burden of COVID-19 on expectant mothers, she experienced exactly that, giving birth to her first child, Naseem, a beautiful baby girl, during the apex of the quarantine in the epicenter of the pandemic, New York City. With that, Dr. Rasha Khoury.
Thank you, Dr. Lakhani, so much for that kind introduction. So as a physician and a Palestinian woman who grew up in East Jerusalem and is working currently in the Bronx, the last 6 months of the COVID-19 pandemic, both in my work in the Bronx in New York, but also internationally with Doctors Without Borders, has really been about the intersection of who I am and what I do. The pandemic has brought into sharp focus and into actually mainstream medical discourse the importance of thinking about, talking about, and centering social determinants of health. So these are beyond sort of things beyond the biologic indicators of age or social indicators of gender, race, and ethnicity, and are really sort of one layer out, looking at the environment where people live, the social fabric in which they live, what types of access to food security or insecurity do they have, what is the economic and sort of labor force that is surrounding their lives. And this is the idea that we actually look at how these impact people's health outcomes beyond just looking at behaviors or education level. And housed sort of around that is these ideas around structural determinants of health. So governance, politics, the policies that determine, residential segregation, or what kinds of resources are pooled into communities or pulled away from communities that may advantage some groups over others. And I feel a personal relationship to these concepts because this structural sort of barriers by design has really been formative for me as a person who grew up in East Jerusalem, which is very much a divided and further fragmented city. On the left here is an image of the actual physical barriers that control movement and human flow into and out of the city. This is a contemporary military checkpoint that divides East Jerusalem from the West Bank. And pictured here are women and children, which are the sort of vulnerable communities within vulnerable communities that I take care of as a health professional. Jerusalem is, as I said, divided and fragmented, but this is really by design. So it is a way to sort of further subjugate a certain group of people, but it really means it controls how people move, who they marry, where they live, what types of health access they have and health quality, what kinds of transportation they take, and how much time they may spend sort of seeking care. An example of crossing this particular checkpoint can take anywhere from 1 hour to an entire day. On the right here is a map of Jerusalem as it was divided in 1948-49. And it's just to show that what the effects that we're seeing today in Jerusalem are really, decades and decades of work and planning in the past that creates the inequities that we see today. When we think about COVID in Jerusalem, actually, I wanted to show you a map of COVID-19 in Jerusalem. And in fact, data on COVID-19 in East Jerusalem does not currently exist. It is not currently reported by the World Health Organization, which really does not include the whole world. And this is another way of sort of invisibilizing certain groups. And an American audience is very familiar with this process of invisibilizing groups, or having data report on certain people but not others, because I think COVID really brought that home. So in the Bronx, what we've seen on the left here is the cases of COVID per 100,000 residents. And as you can see, the darker the color, the more cases. The Bronx, for those of you who are not familiar with the map of New York, is sort of the very top of this map. In the lighter pink colors, with the gray rectangle in the middle, which is Central Park, that is Manhattan. And so you can see the contrast between Manhattan, where we have some of our wealthiest zip codes and residential areas, compared to the Bronx, which actually is the poorest borough in New York City, and is home to one of the poorest congressional districts in the entire United States. The Bronx is also home to primarily minoritized groups, primarily people living in poverty. The map here on the right is called a quote unquote security map from New Deal America in 1938. And it's highlighting the homeowners, loan corporations designation of desirability of residential areas. So in red and in yellow are what's called hazardous or undesirable areas to lend mortgages in. In green and blue is sort of the more desirable ones. And this actually policy in 1938 really impacts housing quality today in the Bronx and who lives where. And it's a very sort of bleak example of how social capital and investment is shifted away from certain communities and towards other communities. And fundamentally, this impacts people's health. So as Dr. Lakhani mentioned, I'm a physician for women with higher risk pregnancies. And so I've been primarily focused through this COVID-19 pandemic on the impacts on women, fetuses, pregnancy outcomes, and infants. And the CDC actually a little bit late started to report race, ethnicity, language, and breakdown of the impact of COVID-19 across the US. And what you can see from this bar graph, the absolute numbers are not what's important, but the disproportionate impact on Latinx and Black women when you look at the proportion that they are in the US population compared to the proportion that they are of positive cases is really something that's both unshocking to anyone who's been engaged deeply in public health in the United States in the last decades, but also very alarming. And the reason that I say it's alarming is in the US today, one of the highest maternal mortalities in sort of equivalently developed countries around the world, 700 women are dying every year in the US from pregnancy-related reasons, and 65,000 plus are suffering life-threatening morbidities, near misses, emergencies that could have led to death, but didn't. 4 to 5 times Black women compared to white women die in the US from pregnancy-related causes. And in New York City, this number is up to 12 times. So a Black woman is 12 times more likely to die of pregnancy-related complications than a white woman in New York City. And often I say this statistic, and people who may be sort of less familiar will say something about the impact of poverty or education. But in fact, when you look at Black women with a college degree or higher as compared to white women with a high school degree or less, this disparity persists. And so this drives home how important, the work in the last 6 months has been among communities that are considered vulnerable, that are marginalized, that are otherwise invisibilized, and the importance of people like us, public health professionals, physicians, to tell the stories of of the communities that we're caring for, and to really tell the stories with communities. So nothing about us without us is for us is a slogan of many different groups in the United States, but also around the world. But it really brings home this idea that professional organizations, community organizations, medical organizations need to collaborate with the communities that they serve in order to tell the stories of, in my example, women and children of Black and Latinx communities, or women and children in Afghanistan, and the toll and burden that they bear because of the pandemic's sort of unraveling of already very fragile states and safety nets or lack thereof that they have access to. I'm so honored to be able to have shared, some of my personal and professional background with you today. And really this talk is about, this is exactly who I am. This is what I do and what I work to do every day. And what I hope for is really this final message that nothing can be about us without us. And I thank you so much for your attention.
Thank you, Dr. Khoury. So just one question. What do you hope for?
What I hope for in general, sort of pre-pandemic or outside of the pandemic, but also what's been, I think, accentuated by the pandemic, is that we really pay attention to the most vulnerable communities and the most vulnerable groups within those communities.
And hopefully you've inspired us to tell their stories. Thank you so much for joining us today, and thank you to the audience for joining us today. I appreciate your story and how you've inspired us, and I hope you'll join us for the rest of the lightning talks.